Bismillahirrahmanirrahim. My name is Dr. Arif Zaheer and I am working as a professor of pediatrics at PGMI Amiruddin Medical College, Lahore General Hospital. Today we will start our discussion with a scenario. This scenario is about a child who is 9 years old, a female patient, and presented with 6 months history of low-grade fever, anorexia, malaise, and weight loss. On examination, she is pale and has mild jaundice. The liver is tender and palpable by 3 centimeters below the costal margin, and the spleen is also palpable about 2 centimeters below the costal margin. Investigations revealed serum bilirubin level 3 mg per deciliter, ALT 230 international units per liter, serum albumin is 2 mg per deciliter, which is low as compared to the normal, and serum IgG levels are 25 gram per deciliter, which are raised. The normal value is around less than 16 gram per deciliter. Moreover, the serological tests for hepatitis A, B, C, D, and E, they are also negative. So the questions which could be asked in such a scenario are: what is the most likely diagnosis? What other investigations can help you reach a diagnosis, as well as to differentiate it from other conditions? And you may be asked that name the drugs with their dose and side effects, and what are the new drugs or other drugs which can be used to manage this condition. Now, if you look at this scenario, you can see that this girl has a long or chronic history of ailment. She is sick for the last 6 months, and she has jaundice, she has liver enlargement which is tender, and then spleen is also palpable, and then the investigations revealed elevated levels of bilirubin, ALT, low level of albumin, and high levels of immunoglobulin G in the blood. The serology for hepatitis A, B, C, D, and E are negative. So it is quite clear that this child is having some chronic liver disease, and the cause is not infective, as serology for all the infectious agents causing hepatitis is negative. But the one very important investigation which is given in this scenario is the raised levels of immunoglobulins, which happens when there are elevated levels of autoantibodies in the serum. So if we analyze this scenario, then we come to the conclusion that this child is having some autoimmune process which is damaging the liver, and this condition is called autoimmune hepatitis. So autoimmune hepatitis is a chronic disease which damages the liver, and it results from antibody formations, autoantibodies formation in the human body. The learning objectives of today's discussion are that by the end of this lecture you will know the definition of autoimmune hepatitis, you will know the etiology of autoimmune hepatitis, signs and symptoms of the autoimmune hepatitis, and how we diagnose this condition. Then you will also know the important management steps of a case of autoimmune hepatitis, and there will be few words regarding the prognosis of this condition. What happens to the patient when he recovers or does not respond to the treatment? That is known as the ultimate prognosis of this condition. Now, as far as the definition is concerned, the autoimmune hepatitis is a disease in which the body's own immune system attacks the liver, causes it to become inflamed. The disease is chronic, meaning that it lasts many years. If it is left untreated, it can lead to cirrhosis and of course liver failure. There are two forms of this disease known as autoimmune hepatitis type 1 and autoimmune hepatitis type 2. The autoimmune hepatitis is a non-resolving chronic liver disease that affects mainly female and is characterized by hypergammaglobulinemia. It is characterized by circulating antibodies and certain HLA types, that is human leukocyte antigens, DR3 or DR4, genetically predispose this child or patient to autoimmune hepatitis. Then there are very peculiar histological changes in the liver that occur, and they help in the diagnosis of autoimmune hepatitis. As the disease is immune mediated, it results from faulty functioning of the immune system. So this condition responds to immunosuppression. The immunosuppressive drugs like steroids, like azathioprine, like 6-mercaptopurine, they are helpful in the management of this condition. And if this condition is left untreated, as I have already discussed, it can lead to cirrhosis, liver failure and death. And in case of cirrhosis or in case of liver failure, the only remedial treatment is the liver transplantation. Now, what is chronic liver disease? The chronic liver disease is defined as when the duration of liver disease is more than 3 to 6 months, or when there is evidence of chronic hepatic decompensation, that is the less levels of albumin, which is normally synthesized in the liver, and thrombocytopenia, which may be due to hypersplenism. And then when the physical stigmata of chronic liver disease are present, like clubbing, like spider nevi, or the spider telangiectasias, splenomegaly, and ascites. So if This situation arises that the patient has liver disease for more than 3 to 6 months. There is evidence of hepatic decompensation in the form of hypoalbuminemia, thrombocytopenia, or when there are stigmata of chronic liver disease like clubbing, spider telangiectasias, splenomegaly, then or the ascites, then this is known as chronic liver disease, and autoimmune hepatitis is a chronic liver disease. Now, the etiology of this condition is generally not known. It's not clear what causes immune-mediated damage to the liver. Exact cause is not known, but various environmental factors, which are known as triggering factors, they can precipitate this condition in a genetically predisposed patient, particularly when he has HLA antigens DR3, DR4 or DR7. The precipitating factors or triggering factors are infections, drugs, or toxins. The clinical manifestations of this condition are quite variable. On one hand, the child may be clinically asymptomatic, but on the other hand, he might have fulminant hepatic failure, and initially in about 20 to 30% of the patient, the illness mimics acute viral hepatitis. Now, as far as the symptoms of this condition are concerned, the patient feels fatigued, and this symptom is found in about 86% of the patient, and then the patient will have jaundice, which is present in 78% of the patient, abdominal pain in 48% of the patient, particularly in the right hypochondrium, and then due to the cholestatic jaundice, they can have pruritus, which is present in about 36% of the patient. Patients are generally anorexic, and they can have involvement of the other organs, like they can have arthralgia, they can have arthritis. General symptoms include nausea, vomiting, and fever. They can have maculopapular rash, and sometimes they can have manifestations resulting from vasculitis like erythema nodosum, and then they can have Coombs test positive hemolytic anemia, and then they can have features of concurrent immune disease like Hashimoto's thyroiditis, like nephritis. Now, if you look at the signs resulting from the chronic liver disease or chronic autoimmune hepatitis, they include hepatomegaly, which is found in about 78% of the patient, while the splenomegaly is found in about 32% of the patient. Almost 70% of the patients have jaundice, and they have concurrent immune disease like Hashimoto's thyroiditis, like nephritis, and this is found in about 38% of the patients. Due to the chronic liver disease, they can have ascites, and ascites is found in about 20% of the patient. 14% of the patient, they present with hepatic encephalopathy, and these patients are of course delirious and comatose. The stigmata of chronic liver disease may be present like clubbing and ascites and spider telangiectasias. Now, in the next few slides, I will show some important pictures which are related with this lecture. And this slide shows jaundice. You can easily see that there are yellowish discoloration of the skin and sclera, and this condition is known as jaundice. Jaundice can also be seen in the palmar crisis. So yellow discoloration of skin and sclera is known as joints. Then we have clubbing. Clubbing is increase in the curvature of the or longitudinal and transverse curvature of the nails, and at the same time there is loss of angle between the skin fold and the nail bed. Commonly this condition arises from cyanotic congenital heart diseases or lung pathologies, but it can also develop in patients who have chronic liver disease, who have malabsorptive syndromes like celiac disease, and of course many other heart problems like infective endocarditis. Now, these are the spider nevi which are on the trunk, and these are obviously linear shadows, linear vessels with a large central arteriole, and if you will press this area it will blanch on pressure, while most of the other vasculitic lesions do not blanch. So there will be a central arteriole with small linear vessels arising from this area, and if you press this area there will be blanching. So these are known as spider telangiectasias, which are found in chronic liver disease resulting from any cause like hepatitis B, C, or Wilson disease, or the autoimmune hepatitis. Now, this picture shows erythema nodosum. There is a large tender red nodule, and these are mainly found on the extensor surface, and this can also arise in patients with chronic liver disease. This slide shows a patient having massive ascites. You can see that abdomen is massively distended, and there may be small veins visible around the umbilicus, which is known as caput medusae. And so if you will perform the fluid thrill on this patient, it will be positive. So fluid thrill is present when there is massive ascites, and this can happen in a patient who has chronic liver disease. Now, what are the investigations that can help in the diagnosis? The investigations that can help in the diagnosis are the serum aminotransferases, which are elevated, like ALT, AST. They may be in the range of 100 to 1000 international units per liter. Serum bilirubin is increased, and this is generally a conjugated bilirubin. And then serum alkaline phosphatase and gamma glutamyl transpeptidases all may be increased, but they are generally raised in sclerosing cholangitis, or when there is some obstruction, for example due to political cyst. So these are increased. Then serum gamma globulins are markedly elevated. The rise in the serum gamma globulin indicate that some immune process is going on which is causing hepatic injury. Then the synthetic functions of the liver are deranged. For example, albumin is not synthesized, so the levels of albumin will fall, and the low levels of albumin will further add to the development of ascites and edema. Then, due to the deficiency of coagulation factors which are synthesized in the liver, particularly the vitamin K dependent factors, The coagulation pathway will be affected and the patient will have prolonged prothrombin time. The patient will be anemic and will be having normocytic normochromic anemia. They can have leukopenia and thrombocytopenia. These findings in the peripheral picture generally indicate that this child or the patient might be having hypersplenism, which is there in almost many patients who are having some chronic liver disease, particularly those who have splenic enlargement. The other investigations which can be ordered or which can be carried out are the autoantibodies like anti-actin, which is also known as anti-smooth muscle antibodies, anti-nuclear antibodies, and these are generally raised in type 1 autoimmune hepatitis. Then the liver, kidney and antimicrosomal antibodies, which are generally raised in type 2 autoimmune hepatitis. Then we can have anti-neutrophil cytoplasmic antibodies. Then, as it has already been mentioned, that there may be many other diseases which are immune mediated and which may coexist with autoimmune hepatitis. One of them is Hashimoto's thyroiditis, so there may be anti-thyroid antibodies which may be raised, and then there may be antibodies which are formed against the RBCs and they can cause hemolysis, and and these antibodies can be detected with the help of a Coombs test. Ultrasound abdomen will help in the diagnosis of cirrhosis of the liver and in case of many obstructive conditions like cholelitical cyst or malformations of the or obstruction of the biliary tree. Appropriate serological tests must be carried out, like serological tests for hepatitis B, C, because hepatitis B and C cause chronic liver disease. Hepatitis E can cause chronic liver disease, but only in immunocompromised, immunosuppressed patients. Then MR cholangiography is helpful in the diagnosis of sclerosing cholangitis. Autoimmune hepatitis may be a part of celiac disease. So a patient who presents with celiac disease or with autoimmune hepatitis must be thoroughly investigated, and a patient having autoimmune hepatitis must be investigated for anti-tissue transglutaminase antibodies or anti-endomycin antibodies. The anti-tissue transglutaminase antibodies or the anti-endomycin antibodies, they help in the diagnosis of celiac disease. So we have to investigate for the conditions which can coexist with autoimmune hepatitis, or in which the autoimmune hepatitis can be a part of some other disease process. Now, on histology of the liver, we will find evidence of chronic hepatitis with marked piecemeal and bridging necrosis, and there may be lobular involvement. There will be numerous plasma cells. The interface hepatitis is a hallmark finding or the hallmark feature in the histopathology, and there will be necro-inflammatory activity, there will be necrosis of the cells, and there will be inflammatory process going side by side, and at the same time there will be evidence of hepatocellular regeneration as well. And this picture shows the histological picture that we find in cases of autoimmune hepatitis. So there is dense fibrosis in the area of pleural tract, along with infiltration by the mononuclear cells, particularly the B cells, T cell, B and T cells, and then plasma cells, and of course macrophages. And this picture is known as interface hepatitis, because there is dense infiltration in the portal area, and these cells, they invade the surrounding parenchyma. So this picture, this histopathological picture, is known as interface hepatitis, and this is a hallmark of autoimmune hepatitis. So now, how can we diagnose the patient? Uh, Diagnosis is based on the history and examination, and of course investigations. The important positive points are that this condition generally develops in females, and there will be elevation of bilirubin, there will be elevation of transaminases, and above all there will be elevation of gamma globulins. Similarly, the other antibodies like anti-nuclear antibodies, anti-smooth muscle antibodies, or anti-LKM, that is liver, kidney and microsomal antibodies, will be elevated, and on biopsy there will be characteristic histological finding as have already been discussed. Then there are certain negative features, that is the absence of viral markers indicating that this condition is not resulting from any chronic viral infection like B, C or E in immunocompromised patient. Similarly, absence of use of certain hepatotoxic drugs like INH, like rifampicin, like sulfonamides, or repeated blood transfusions or transfusion of blood products, which can cause infective hepatitis in the form of hepatitis B, hepatitis C, or other infections like cytomegalovirus infection. The differential diagnosis, of course, includes viral infections, hepatitis B, C, and E, and then certain metabolic disorders like Wilson disease, like alpha-1 antitrypsin deficiency. In case of Wilson disease, we can confirm the diagnosis with the help of raised with the help of cellular plasmin level, which is generally low, or the increased excretion of copper in the urine, which is determined in the 24 hours urinary sample, and the alpha-1 antitrypsin deficiency is diagnosed by doing the genotyping of the patient. Certain drugs can cause chronic hepatitis like INH, sulfonamides, methyl dopa, and many sulfur drugs. So history is of utmost importance. And similarly, the inflammatory bowel disease like Crohn's disease can present with autoimmune hepatitis. Celiac disease may be associated with autoimmune hepatitis. So these patients must be investigated, and we must do the anti-tissue transglutaminase levels and anti-endomysial antibodies to diagnose celiac disease and to differentiate the between the different causes of chronic autoimmune hepatitis. Now the treatment. Obviously, the goal of the treatment is to suppress or to eliminate the inflammation so that the disease can be controlled and its progression may be curtailed or slowed down. And at the same time, our aim is that the patient should have minimal side effects of drugs. Generally, the mainstay of the treatment is prednisolone with or without azathioprine or 6-mercaptan 6-mercaptopurine. These drugs will improve the clinical condition of the patient, the biochemical condition of the patient, and of course the histological features of the disease when we do the liver biopsy. Now the drug which is commonly used is the prednisolone. The dose is 1 to 2 milligram per kg per day. When there is clinical biochemical response, and particularly when the histology on liver biopsy appears normal, the drug can be tapered to a dose which is as low as 0.1 to 0.3 milligram per kg per day. Azathioprine in a dose of 1.5 to 2 milligram per kg per day with a maximum dose of 100 milligram per day, it can be used in patients who respond poorly to the steroids or who experience the side effects of the steroids, or the patients who cannot be maintained on low dose steroids, and on low dose steroids they experience relapses. So we have to switch over to other drugs like azathioprine. And the other drugs, other immunosuppressants which can be used in a patient with autoimmune hepatitis are cyclosporins, tacrolimus, mycophenolate mofetil, and sirolimus. But remember that the mainstay of treatment, or the golden drug which is used in the treatment of autoimmune hepatitis, is the prednisolone. So when to discontinue treatment? When the patient is asymptomatic, there is clinical improvement, when the patient shows biochemical improvement, that is the ALT is less than 2 times the normal upper value, and similarly when the biopsy shows that there is resolution of necro-inflammatory process and there is no ongoing damage, only then we can stop the treatment. But once the patient develops cirrhosis, or in some cases acute fulminant hepatic failure, the only treatment or the treatment of choice is the liver transplantation. Now, the prognosis of this patient, or the patients suffering from autoimmune hepatitis, is that when we start the treatment, particularly with the steroids, 75% of the patient go into the clinical and biochemical remission, generally within the first 1 to 3 months. In these patients, we can do the liver biopsy, and at the same time we can start tapering the steroids, which are generally tapered to the minimum dose over the period of next 3 months. And if the biopsy report is normal, only then we can think of stopping the treatment. If the biopsy is not normal and there is continuous necro-inflammatory process going on, then there is a very high risk of relapse. So in all those patients in which we stop treatment on the basis of clinical and biochemical remission and do not do the liver biopsy and do not look for the resolution of necrosis and inflammation, the chances of relapse are very high. About 50% of the patients show relapse after the treatment is withdrawn. So we will have to institute treatment for a prolonged period of time. Only the treatment can be stopped in those patients who have clinical improvement, who have biochemical improvement, and who have histological improvement on histopathology, on the liver biopsy. There is no evidence of necroinflammation. So in these patients, if we stop the treatment, the chances of relapse are minimal. But if we stop the treatment much earlier, or on the basis of clinical and biochemical improvement, the chances of relapse are very high after we withdraw the treatment. So in the follow-up of the patient, we have to monitor the linear growth, we have to do the ophthalmoscopic examination because the patient is on steroids and he can have cataract. Then bone density measurements is important because there may be osteoporosis due to several factors like poor intake, like use of steroids, like low levels of vitamin D, which is a fat-soluble vitamin, and of course which is not absorbed from the GIT along with other fat-soluble vitamins. Then the blood pressure should be measured. The other side effects should be looked, particularly the side effects of the steroids and side effects of the any other cytotoxic drugs being used in the management of this condition, like azathioprine, which can cause bone marrow suppression, and that will be associated with leukopenia, anemia, and of course low platelet count. And we must examine the patient for the progression of the disease, progression to the cirrhosis. In such cases, ultrasound will show that liver is showing increased echogenicity and is shrunken, and there is a increase in the portal pressure along with splenomegaly, and there might be evidence of free fluid in the abdomen. So we have to follow these patients very carefully, not only for the activity of the disease, but also for the side effects of the drugs which are being used. Now, if we summarize today's discussion, we can say that the autoimmune hepatitis is a autoimmune process that results from the antibodies which are formed against the liver cells, and they cause the chronic inflammation and necrosis in the liver, leading ultimately to the cirrhosis or liver failure if it is not managed properly. And there is increase in the level of various autoantibodies like anti-smooth muscle antibodies, RNA antibodies, RA factor, Coombs test positive, and there will be LCAM antibodies, and there will be elevated levels of anti-neutrophil cytoplasmic antibodies. There may be antibodies formed against other organs like thyroid, and the patient can have Hashimoto's thyroiditis, so there will be elevated levels of anti-thyroid antibodies. Prednisolone in a dose of 1 to 2 mg per kg per day in divided doses until the ALT decreases to less than double the normal value, and it is then tapered to a dose of 0.1 to 0.3 mg per kg per day is a mainstay, is the mainstay of the treatment and important drug which is used in the management of autoimmune hepatitis. Similarly, other drugs like azathioprine, 6-mercaptopurine can be used in the management of autoimmune hepatitis. Long-term monitoring is very important, and the patient should be monitored not only physically but also the lab values should be determined. So in the end, I will thank all the listeners for their patient listening and taking interest in the time in the topic and taking out